Okay, so earlier in this presentation, you heard a lot about the Affordable Care Act, and you heard that our expectation is that as we cover more people in the U.S., we're going to need more health professionals to meet increased demand for health services. So this next segment is about how we're going to supply enough health professionals in order to meet that increasing demand. And we're going to talk a little bit about that aging population. We're going to talk about existing shortages in health professional labor. And we're going to talk about, can we use other kinds of health professionals to fill the gap of physician shortages? So the slide you're seeing now looks at how physician utilization or utilization of physician services changes as people age in our country. And you don't have to dig too deeply in to see that when people get to the point that they're 75 and older, they use a lot more health services than they do even when they're kids, even if it seems like you take your kids to the doctor all the time. So one of the issues is to try to figure out, both with this and then with expansions that are going to be needed for uninsured people, you know, how are we going to in the future face this increasing demand? Especially when we look at the distribution of health professionals in the U.S. What you're looking at now is a map of designated health professional shortage areas. There's a lot of little colors here, but basically I want you to focus on the red. Those are counties where the whole county is a shortage area. And you'll see that really there's some large parts of our country that are shortage areas in the more rural areas, more mountainous areas. We don't have shortages here in the Northeast where I am. We may have spot shortages in tiny little counties, but again, those tend to be counties that are also rural or more remote. And I told you earlier, many of these states are also states where there's been very little by way of money to train more residents within those states. So part of what we're trying to do right now is train people in some parts of the country and then hope that they move to other parts of the country to help meet these shortages. One thing that's happened over the thinking about the Affordable Care Act is to really think about our full-time equivalent, and those are what FTE stands for here, of primary care providers. And you're looking now at a chart between 2010 and 2025. You'll see here that we don't expect, right now anyway, huge expansions in the number of healthcare primary care providers, especially physicians. We're not planning as of now to train a lot more primary care physicians. A lot of the new policy is presuming that what we're going to do to make up for this demand for primary care is to train more nurse practitioners and perhaps more physician assistants, a profession that's small right now but growing. The idea here is that not every form of primary care service has to be delivered by a doctor, but nurse practitioners and physician assistants can be trained and educated to provide a lot of the basic primary care services that are needed in our country. And it's also, faster and less expensive at the moment to train a nurse practitioner. So a lot of workforce models are relying on growth in what some folks call physician extender professions. That term can be a little bit controversial. I prefer to just name them as nurse practitioners and physician assistants. So can these new professionals fill the gap in primary care supply? One thing, I'm not going to spend a lot of time on workforce modeling, but one of the things you have to realize when you're trying to figure out, do we have enough doctors, do we have enough nurses, is whether, or all of the little components that might go into that. How many hours do people work? Are they covering, large patient populations or small patient populations? Are they working nights? Are they working shifts? Are they on call for periods of time, and do we have to pay them to be on call? People's preferences for work shifts, for Work settings may drive these models. The gender of the workforce may drive these models. The marital and family status may drive these models. So they're complex models, and small changes can make a big difference as we're trying to say, really, do we have enough doctors? Do we have enough nurses? We know there are 36 million currently uninsured and lacking access, who lack access to primary care physicians. Not all the uninsured in our country lack access to a primary care physician, but many do. And a full 30% of those folks are living in those primary care shortage areas I showed you earlier. We've shown you some of the projected primary care physician shortages over the next decades. And we know as people get health insurance through the Affordable Care Act that these people are going to be using more services. So we're going to plan to be adding 15 to 24 million new primary care visits over the next decade. Right now, the preponderance of the evidence for most primary care services is that the quality of care delivered by nurse practitioners and physician assistants is similar to or better than what physicians can provide in that setting. And in that place where I said better than, it looks like nurse practitioners are really quite good at helping, diabetics keep to their regimens, helping people with chronic illness manage their chronic illness. Nurse practitioners have filled a critical gap in those shortage areas with rural or underserved populations. And so it's not a surprise that there's been substantial government investment planned in the NP workforce. So what can nurse practitioners do, and how is that politically playing out? Right now, one of the main interests in nurse practitioners is that they're only billing at 85% of the physician fee. So for many types of service, they do essentially the same work, but they get paid less. If you start adjusting those models thinking you're going to pay them the same amount of money, some of the savings by employing nurse practitioners may have to shift as well. Over this period of time, over the time that NPs have been developing, states have changed these regulations. We talked about state regulation earlier. And there's been an increasing push for NPs to be able to practice independent of physicians, especially driven by these shortage areas. If there isn't a doctor around, can the nurse lead a practice? That, as you might imagine, is pretty controversial. And so despite the expanding role of the nurse practitioner, there are still a number of states which require physician oversight of nurse practitioners in many aspects of their practice. There are about 16 states with very broad scope of practice allowed, including independent practice. And as I said, we really expect this workforce to grow. My colleagues, Peter Bierhaus and David Auerbach, have done a lot of this work out of Vanderbilt, and really important work trying to model the impact of this workforce. In 2010, the Institute of Medicine came out with a set of recommendations on the future of nursing that have proved very controversial and created a lot of discussion. These have also been really fueling a lot of initiatives within HRSA and the Affordable Care Act to increase this supply of nurse practitioners as a way of responding to primary care shortages. And so they really, the IOM recommendations really talked about these expansions in the National Health Service Corps, in particular as they apply to nurse practitioners. They have pushed through that community health center money, trying to earmark money for expanded NPs in those settings. There's a request for nurse-managed clinics and expanding scope so nurses can manage their own clinics, home visiting program expansions, and an increasing amount of money directed at nursing education. We talked before about how much goes to physician education from Medicare. Medicare is now making an investment in nurse practitioner education. Huge controversy here, okay? We have many physician professional organizations taking up arms and fighting this out in the states as well as federally, challenging a notion that nurse practitioners can practice independently, challenging the leadership of patient-centered medical homes, which we'll talk about in a little bit, challenging admitting privileges in hospitals, skilled nursing facilities, and hospice facilities, and challenging in particular a recommendation that nurse practitioners be paid equally for equal service. So these battles continue and will, I think, continue to play out. This past year, I published a paper with my colleagues Peter Beerhouse, Kate DeRoche, and Bob Dittis in the New England Journal of Medicine, looking at primary care physician, you'll see the PCP there, nurse practitioner, primary care nurse practitioner, the NPs here, looking at their perception of primary care workforce supply. And without taking you through all the detail here, I think more than 80% of both nurse practitioners and primary care physicians said, we really have a shortage of primary care physicians in this country. A majority of both groups, though with some disagreement, also agreed that there's a shortage of primary care nurse practitioners in the U.S. And on the other hand, these seemed a little less intense. The perceptions of shortages seemed a little less intense in the communities where people practice. And that shouldn't be a surprise if you think back to that shortage map, because there are areas where there aren't shortages, and there are many areas where there are. So, but we don't really see it playing out in the local community yet. You have about half who still see this primary care physician shortage, and the numbers are a little bit smaller around the nurse practitioner shortages. Huge differences between these professionals on the potential impact of increasing the nurse practitioner supply in primary care. We have nurse practitioners really ready and willing and saying we can make the health system better in many ways: safety, timeliness of care, effectiveness of care, if we expand a supply of nurse practitioners. We have a lot of disagreement from physicians around anything really, but timeliness and access to care for the uninsured. Fewer than a third really believe that increasing the supply of nurse practitioners will have a positive effect on safety or effectiveness of care. So you start to see where some of these conflicts come from. So that's a brief summary of some issues around supply and demand. And again, the key issue here is to remember the controversies that are there, but also the opportunity.